Welcome, Dr. Parodi, to the Texas Heart Institute podcast on living legends and luminaries in endovascular interventions. It's a special pleasure and honor to be recording this podcast with you. You are a great luminary and a great friend of mine, and you are one of my greatest idols that I had practicing medicine.
Thank
So,
you so much.
you're welcome. So let's start this podcast with a question that's extremely important as far as evolution of endovascular medicine is concerned. What were the reasons for you to pursue the concept of endovascular abdominal aortic aneurysm repair?
I was a resident at the Cleveland Clinic in 1976, and they were very good. Cleveland Clinic always has been the number one. But we were doing cases, very old patients, and the complication rate was very high. One day we had two patients older than 80 dying in the operating room and having myocardial infarctions. And I told Edwin Bevan and Al Humphreys, who were the staff member, you listen, I think we have, we are being too aggressive with these very fragile patients, and we need to do much less. It's not that the method is bad done, but because it's too aggressive. I think we need to do something like building a sheep into a bottle, that is building a new artery inside the aneurysm. And the following day, I was with bioengineers in the bioengineering department in Cleveland, and the idea was simple, just build a build a new artery, and the new artery was just a tube. Initially, we were just thinking about tube. Then we started with the uni-iliac, and then the auto-uni-biiliac. But initially, it was just a tube with patient with proximal and distal neck. And and what we did is just with using Dacron, and I was using nitinol and stainless steel to fix and seal the ends. And we started to do dogs, and very soon we learned that was pretty easy. And after a month, I was called from Buenos Aires by the president of Argentina, and he had a relative with a 9 centimeter aneurysm, a bad heart, and pulmonary problems. And he learned that I was doing experiments with less aggressive treatment. And he asked me, "Would you do it to my relative?" Yeah, let's meet with him and see. And this guy had an aneurysm, was a big aneurysm, but the distance between the renal artery and the aneurysm was about 2.5 centimeters. And before the bifurcation also was about 2 centimeters. So anatomically, it was pretty easy to do it. And so we met with him and his family, and I explained that he was going to be the first human being, and they agreed. And then the following day, I did it on the local in about 30 minutes. And then I did an open case that was waiting. And then I went to have dinner. And after dinner, I went back to the hospital to see the patients. And amazingly, the patient who had the endovascular treatment was sitting and eating dinner in his room. And Julio Palmas, who was visiting me, he told me, he said, Juan, if this is durable, it's going to make a big impact. And that was the first patient. Actually, he lived for 9 years. Then we did 5 more cases. One was a dissection of the infrarenal dissection, and 4 others. And I presented this in the Society for Vascular Surgery meeting, and I had to repeat the conference twice because the room was not big enough to have all the people there. And after that was amazing because everybody invited me, and I started to do cases in many countries. Then I started to do urouniiliacs, urobiliacs, and later on, Schroeder started with branches, and today my son is doing arch replacement, branch replacement, and actually the results are so good that they actually they don't have mortality. They do that at the local, and so I'm very happy with this. I think it was a very successful project.
Thank you, Juan. So, in your assessment, what is your assessment as far as the current status of EVAR and TVAR and impact on thoracic and abdominal aortic aneurysm repair? You mentioned that now your son and others are doing it under local anesthesia and percutaneously. So, you think that the great majority of those type of conditions can be now treated by endovascular approach?
Yeah, absolutely, absolutely. Um, Someone told me that about 80% of the patients in his place are being treated endoluminally. Um, and obviously, see, if the anatomy is the right one, it's much easier to do endo than open.
And that's thanks to you, Juan, and your vision and your innovations. So we have to mention that that first EVAR in Buenos Aires, Argentina, was done on September 7th, 1990. Yeah, so and the rest is history.
Yeah, yeah.
Very good. So Juan, tell us a little bit about what is missing with today's endografts and what needs to be done to improve the outcomes. And I know this is a very dear subject of yours.
Yes, last year I went to San Luis because I spent many years at WashU. And in San Luis, I found one of my patients who, when I treated him, he was 16 and he had a car accident and a transection of the aorta. And I treated him immediately because he was in bad shape, very hypotensive. I treated him with endografts and he survived. And that was in 2004. And this was in 2024. And he was hugging me, see, I owe you, but the only problem I have is my hypertension and my heart that doesn't tolerate the hypertension. So I started to take a look to that problem and also calling the young patients that I was treated at that time. And I found that all the young patients, all of them were hypertensive. All of them had heart failure, some, and some had dysfunction, diastolic dysfunction. And I started to do some studies in vitro. And then I learned that every young patient that, because life expectancy many patients is very short. We treated patients who were 90 years old, but those patients that were 16, 20, 25, all of them had the same problem. And then what I did is, in the model, silicon model, I reproduced the anatomy and the physiology. I found that the problem was rigidity, that the aura is 5 times less rigid than the endograft we place. And in that way, you explain why you have systolic hypertension, diastolic hypotension, dysfunction, cardiac dysfunction, is because of the rigidity. And it's very, very important because, as I said, it's 5 times more rigid than the aura. And I thought I need to develop an expandable endograft, and I started to work with a group of people, and we found that um, the synthetic rubber, had the same elasticity than the aura, and so we put 2 layers of synthetic rubber. The outer layer was impervious to prevent tissue ingrowth from outside, because I remember Silagi, he was showing us that when the tissue was growing from outside, in few years the patient had a rigid aorta, and this was the case with these cases. And so um, we developed a tube graft with 2 layers. One was impervious outside, and the second was porous as an intima, because also we learned from Silagi that if the intima is impervious, the lumen is going to be thrombosed in a week. So we are at this moment working with that model, and we believe that soon we will try this in humans.
Thank you, Juan. This is very interesting. Actually, the name of this graft is pulsating or pulsating endograft, which makes sense because the human aorta and the animal aorta follows the physics of what we call a wind castle effect. So that
Exactly.
means that it contributes to the cardiac output and peripheral resistance, and even contributes to a certain degree, maybe 10% to 20% to the cardiac output, like this was shown, as you told me in the past, dinosaurs had a second heart by pulsating aorta, which is a very interesting and revolutionary concept. One thing what fascinated me always talking to you is you are a superb vascular surgeon, but you have this unique way of looking at the problems with vascular surgery and how to make it simpler. Like Albert Einstein said, make it as simple as possible, but not simpler. And with a primary idea in mind to help the patient in the best possible way. And in addition to abdominal stent graft and now pulsatile stent graft, you also worked on other concepts that were very revolutionary in vascular medicine, such as cerebral protection that you created. And can you tell us a little bit about it during cardiac
Yes,
surgery?
that was done many, many years ago. I was doing an open endarterectomy, Um, and I was using shunts because in Cleveland they taught us that we had to use shunts in everyone. So I was placing the shunt in the distal carotid, and the technician who was taking care of the Doppler, transcranial Doppler, told me, "What are you doing? Because I have a reverse flow in the middle cerebral artery." And so amazingly, that was the case. And the reversal of flow was because obviously the gradient was 12 millimeters of mercury and 10 centimeters of mercury in the vein. And so I started to work with the tube, with the 9 French um, tube and a balloon and a second hypotube and a second balloon and the side port that was introduced through the groin, and the side port was connected to a vein. And I put a filter in the middle. And so doing that, I was getting flow reversal, and I was able also to see all the particles coming to the being trapped by the filter. And 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 I was in WashU, and Greg Sicard said, let's do something. I am gonna do the low risk patients open, and you're gonna do the high risk patients with flow reversal. And guess what? After 3 months, when the residents reviewed the cases, we had no complications, and the open had 3% complications. So that was amazing. And also, Gore, who was interested in this topic, finally bought the company and introduced the flow reversal. Unfortunately, Gore was not good producing the device, and they interrupted that. And but I was invited to Toledo, Spain, to do a case with Enrique Criado, and I do 2 cases with Enrique Criado, and then I was invited to Italy with Giacchino Coppi. I was doing 2 cases. And guess what? In 2 weeks, there were 2 new patents. There were copies of my patent, the the TCAR and the MoMA. That was exactly what I was doing. The difference is that I didn't make any money and they made millions. And
Right. This is truly unfortunate because your flow reversal device was original and unique, and it functioned very, very well. Another area of your interest was, and again, it's related to vascular surgical experience and what the endografts were designed like in early beginnings. Like your early stent graft was basically secured or anchored using radial force or palmas like a large stent. But then you figured out that the surgical approach is better with suturing the graft to the fixed position because some of those balloon expandable or stent grafts or radial force stent grafts could cause in the future potential expansion of the infrarenal neck. And you designed an anchoring mechanism. Can you talk a little bit about that briefly on active fixation of the endografts?
yes, I was visiting a company called US Surgical, and the owner was Leon Hirsch. And he was showing me all of his products. And he told me, why don't you take a look and see if you can use some of these for your ideas. And one of the products was an endosuture for operating hernias and the luminary. And I told you, listen, I can use this tube, make it steerable. And these sutures, that was exactly the suture I ended using. This suture can be fixed the end of the graft and conceal it. So is it okay? I am going to send you an engineer to Buenos Aires, and why don't you work with that in animals and see if you can develop this product. In few weeks, we had this product coming from the groin and fixing the graft, near the renal arteries, and everything was fine. But Leo Hirsch called me. He said, listen, unfortunately, my company was bought by Tyco, and they don't want to continue with this. Bad luck. Okay. But all of a sudden, two guys from Menlo Park, Alan Kaganov and Lee Bolduc, appeared in Buenos Aires. And he said, let's form a company to develop an endosuture to put an endograft. And so I was so naive that I didn't show the contract to the attorneys. And in few months, these guys sold the company to Medtronic by 60 millions, and they gave me $18,000.
Well, that
So
that is
my wife always says, my wife is try not to tell this to your friends because they're gonna realize that you are not very smart, and she's right.
well. You're very sincere. You're a true scientist and visionary in so many areas of endovascular medicine. Juan, it has been a tremendous pleasure to have you as a friend. And thank you once again for the opportunity and by accepting this invitation to join us at the Texas Heart Institute podcast on endovascular luminaries and visionaries like you. Thank you once again for being with us today.
It was a pleasure to talk to you.
Bye.
Bye now.